Good morning, all of you. And I thank the organizers once again for this kind invitation. I'll try to finish my talk in the 15 minutes allotted to me. It's an extensive topic because the topic is pretty ambitious. It is management protocol for undifferentiated carcinomas per primum and recurrent. Each topic could be a lecture by itself, and it can go into 45 minutes. But then I've left the chemotherapy part for Dr. Chirag Desai because I know he's going to be talking after me. So the next thing, of course, we have to understand these differences with nasopharyngeal cancers and other cancers of the head neck region. That is, they are different in causative factors as compared to other head neck cancers. Also, they have an interesting environmental, genetic, and familial and a viral predisposition. But luckily for us, they are chemoradiotherapy, and then because of the location of these tumors, it becomes easier to treat them. Now, we know about the endemic trends of nasopharyngeal cancers. There are certain pockets of high incidence, especially in North America, as well as in southern China, and of course, North Africa. In India, if you look at the incidence of nasopharyngeal cancers, they may be as high as certain parts of southern China, and that's especially in the northeast, where we have these pockets of very high incidence, almost similar to those in southern China. And that's in Manipur, in certain tribes, as well as in Arunachal and Nagaland. Now, even in Tata Memorial Hospital, where we see a very high incidence of head and neck cancers through the year, we have a very low incidence of nasopharyngeal cancers if you look at the other common head and neck cancers. Now, just a word on the staging workup. This is important to keep in mind because before you start treatment or jump into the treatment of nasopharyngeal cancers, it is important to adequately stage them. And luckily for us at the Tata Memorial Center, we have a PET-CT, and we do use a PET-CT as a one-stop shop to stage these patients adequately. But you cannot do away with the endoscopic evaluation and the MRI of the skull base and the paranasal sinus when we are evaluating nasopharyngeal cancers. The other important aspect, which I think is very important today, is estimation of EBV plasma titers, as well as doing all these ancillary investigations because you have patients who are going to live long. And you need to know what their baseline parameters are before you can actually start treatment. Now, one word about the role of PET-CT. It has a role to play both in the diagnostic space. For response evaluation, it has various prognostic importance, as well as it may help decide about treatment intensification. This was our own study which we had done in trying to establish the role of PET-CT in patients with nasopharyngeal cancer. And when we tried to correlate the PET-CT with the anatomic imaging, we realized that at lower values of SUV and metabolic target volumes, actually there was better correlation. But at the same time, what we also realized was that the total metabolic target volume had an impact on distant metastasis-free survival, and partial metabolic response results in poor local control and regional control. There was significant association between total metabolic target volume and metabolic response. Patients with partial metabolic response had higher metabolic target volume. Hence, the baseline investigations are as important as the follow-up investigations. We also evaluated the PET-CT in the post-therapy space, and we realized that patients who had any form of uptake, even in the post-treatment phase, actually did much worse, especially failing distant as compared to patients who did not have any uptake post-treatment. The other important parameter that I have spoken about is actually the estimation of EBV titers. And I'd refer to all of you who are interested to look at this particular paper from Ann Lee, the queen of nasopharyngeal cancer, who actually talks about the role of estimation of EBV titers. And of course, we eagerly await the results of one NRG study, that is the HN001. So it has a role to play in screening, it has a role to play in staging evaluation, monitoring, response assessment. Of course, it has not made itself to the staging evaluation simply because the EBV estimation requires a lot of standardization between labs, and reports from one place may not be same as other places. But of course, we have to remember that it has a role to play in screening, staging evaluation, monitoring, response assessment, and of course, in surveillance. Especially this has a role to play in patients with a high incidence of nasopharyngeal cancers, because simply dependent on the plasma EBV levels, you can decide which patient is perhaps at a higher risk for developing nasopharyngeal cancer and accordingly evaluate this patient further. Now, coming to the pathological classification, this is again important because most of the ones that you see in the endemic areas are the non-keratinizing differentiated or the non-keratinizing undifferentiated. The type 1, which is the keratinizing squamous cell carcinoma, essentially is that form of nasopharyngeal cancer which I consider perhaps, and that's what I tell my residents, may be an extension from the oropharynx, and they do not behave like the undifferentiated carcinoma of the nasopharynx. And most of the data from the endemic regions actually are for the undifferentiated nasopharyngeal cancers. Now, coming to the staging system, we've actually changed the staging system. It is now the 9th edition of the AJCC. And if you compare the 9th edition with the 8th edition, actually in the TNM, the T, there is no stage and no change. And essentially, it becomes very specific and very to the point. That is the only change. But if you look at the end stage, there has been realization that the extranodal extension is actually very important and has a role to play in all stages of the cancer, and hence there is a change in the N1, N2, N3. And of course, in the M category, again, there is a difference depending upon the number of metastases and the number of organs that are involved because of metastatic disease. And of course, so has the staging, the group staging changed in nasopharyngeal cancer in the 9th edition. And you have to remember that all this is backed by solid data of more than 4,000 patients. So the 9th version of the TNM staging for NPC is based on robust analysis and a comprehensive review by the AJCC UICC staging committees, and provides an improved staging system for global application and a framework for future incorporation of non-anatomical factors. And this, of course, has been launched already in January 2025. I usually do not refer to the NCCN guidelines simply because we have our own guidelines for the management, that is the NCG guidelines, but we are in the process of actually modifying these guidelines based on recently available literature. These are the NCCN guidelines as of January 2026. And you can see that for the early stage, it is usually the definitive radiotherapy which still plays an important role. And of course, systemic therapy is to be used in T2N0 if there are high-risk features. In the stage 3 and stage 4, of course, concurrent chemoradiotherapy. And of course, in the advanced stage, that is the loco-regionally advanced stage tumors, you have the role of induction chemotherapy, which is today category 1. Or you could use concurrent chemoradiotherapy followed by adjuvant chemotherapy, or concurrent systemic therapy or radiotherapy. Now, this is one site in the head and neck which of course has evidence for the treatment of oligometastatic disease even at presentation, and this is something that I urge all of you to keep in mind. If a patient presents with oligometastatic disease, please do not write him off. Treat him aggressively, because this patient of course deserves a chance at long-term survival, and we have randomized level 1 data to support the use of aggressive therapy even in metastatic disease. So in short, these are our guidelines, which of course encompass everything that the NCCN tells us today. And the other fact that I'm leaving for Dr. Chirag Desai to handle completely is the emerging role of immunotherapy in various settings in nasopharyngeal cancers. And of course, there are certain other contentious issues. Of course, when talking about nasopharyngeal cancer, we cannot do without talking about this important the intergroup 0099, that is Mufi Alsaraf's study. And of course, we have to look at the use of concurrent chemoradiotherapy in nasopharyngeal cancers. Of course, since we don't have too much data from the rest of the world, the first meta-analysis, there were 2 meta-analyses back-to-back by Borja and Blanchard, and actually it clearly told us that concurrent chemotherapy has a definite role to play in advanced nasopharyngeal cancer. It reduces the rate of locoregional recurrences and also has a role to play in distant metastatic disease and overall survival. So what was the status of chemotherapy? After the first few MAC and PC meta-analysis that we had, Chemotherapy actually improved the locoregional control with the addition of chemotherapy, improved distant control, also improved the progression-free survival and overall survival. But there was poor compliance, especially when people started practicing the adjuvant chemotherapy alone after concurrent chemoradiotherapy, and increased the acute and late toxicities. But the benefit was essentially for the concurrent chemoradiotherapy, and the role of concurrent adjuvant therapy was left unanswered. Do I have to finish? Because then I'll just stop my presentation. Oh, yeah, okay. Then I just talk about radio because I've kind of divided it into sections, so it's easy to stop. Then radiotherapy in nasopharyngeal cancers, you must remember, I won't go through the entire slide, but radiotherapy is the cornerstone for treatment of nasopharyngeal cancers. The challenge, it is a challenge and it is a favorite thing for most radiation oncologists because of the location, the volumes that we have to encompass, the doses that we need to restrict to the organs at risk, the dose volume relationships and contouring uncertainties. This is a figure that I showed yesterday for protons, but this holds true even for nasopharyngeal cancer. And in the era of IMRT, we need to realize that the loco-regional control rates are great. It is upwards of 90%, and actually you cannot treat nasopharyngeal cancers today without conformal radiotherapy fields. And again, this is an important seminal paper by Ann Lee, which talks about the gains that we have achieved with the use of conformal radiotherapy. When we moved from 2D to 3D to IMRT, the essential gain was one, of course, in control, but the other very important thing that conformal radiotherapy gave us was reduction in the late neurological toxicity with the use of more conformal radiotherapy techniques, and this is quite obvious from this table. Again, this is one of those sites in the body which generated level 1 evidence for the use of IMRT in head and neck cancers. You have two other trials by Cam and Paw which actually looked at early nasopharyngeal cancer, and this study by Gangpeng actually showed you for advanced nasopharyngeal cancer how IMRT actually played a role not only reducing the sequelae of radiotherapy, but also in achieving higher local control rates, because with IMRT it was possible for us to give higher doses. We've also published our results from 2D to 3D and how we've improved. But of course, what we have to keep in mind is that despite good locoregional controls, for the locoregionally advanced nasopharyngeal cancers, there is a very high rate of distant failure. And this is our recent data, which we've not yet published. But of course, it goes to show the same thing, that when we have treated patients as per standard guidelines, we do achieve good local controls, acceptable acute and late toxicities, and this is what our survival outcomes are. But despite the improvement in outcomes, what simply remains is that in nasopharyngeal cancers, we have to remember about distant metastatic failure. And of course, what to treat, how much to treat is again very important. And today we realize from evidence that is available that possibly we can limit the amount of uninvolved neck that you need to give doses to with radiation therapy. And these are the international guidelines that are available for the same thing. I again won't be going into details, but again, a word of caution. When we try to reduce toxicity, please do not reduce toxicity at the cost of trying to spare the target volumes. And of course, it is important to classify your organs at risk into various priority levels so that you spare the structures that really require sparing, that is brainstem, spinal cord, optic chiasm. And then, of course, if you see this particular picture, you will realize that it is the oral cavity, postcricoid pharynx, cochlea, mandible, which come to priority 4. Simply means that do not try to spare these structures at the cost of trying to spare trying to give these structures higher doses. Spare these structures first and then try and spare the priority 4 structures. This is the summary for radiotherapy. We have to give complete doses more than 70 gray. Do not exceed a dose per fraction of more than 2.1 gray per fraction. You can use altered fractionation, but not with concurrent chemotherapy. And the type of radiotherapy has to be conformal radiotherapy. radiotherapy. Of course, there is emerging evidence for proton therapy, and there are various randomized trials going on also. But of course, you have to remember that most of these trials look at toxicity reduction and not in improving local controls, because I think we've reached the kind of total doses. We also have a trial that has now been approved for reducing toxicity with IMPT as compared to IMRT. And this is one of the first publications that happened in the proton space in nasopharyngeal cancers, which simply concluded by saying that we could reduce acute toxicity in comparison to IMRT. This is what we have today. We've done more than 26 patients so far with nasopharyngeal cancer, and we'll be starting our trial. But of course, do we need additional chemotherapy? I won't talk about it in too much detail, but today we have level 1 evidence to say that we should be using neoadjuvant chemotherapy. So is the final verdict out yet? This is one of those studies which looked at using triple chemotherapy for induction chemotherapy, the study by Young Soon. And then, of course, you had the GEMSIS trial, which again talked about using induction chemotherapy. And of course, today what we know is that we should use induction chemotherapy, follow it up with concurrent chemoradiotherapy whenever possible in patients with locoregionally advanced nasopharyngeal cancer. It appears to be more efficacious and provides better compliance with manageable toxicity profile. In the interest of time, I think I will just stop here, because recurrent nasopharyngeal cancers actually is a very big ballgame. Also, in nasopharyngeal cancer, recurrent nasopharyngeal cancer, you actually have level 1 evidence to suggest the use of surgery wherever feasible, followed by adjuvant radiotherapy. And even in the adjuvant re-radiotherapy setting, there is evidence again for the use of hyperfractionated radiotherapy. Now, I won't be able to go into the details of all that, and I will stop here if there are any questions. Thank you very much.
Ma'am, for EBV titer, is there any specified range? Suppose if it is a...
Are you going to cover it? Because otherwise I can just tell you the short answer is yes, but it also depends upon the probe that you are using. If you are using the BAM H1W, which is used in South China, they usually follow the cutoff of 2,500, but in Taiwan, it's used as 4,000. So you have to be very sure about what kind of probe you're using for estimation of the EBV titer levels. And actually, you have the NRG HN001, which is looking at this question about intensifying therapy depending upon the levels of the EBV titers.